Marfan syndrome, also called Marfan syndrome, is a genetic disorder of connective tissue. It has a variable clinical presentation, ranging from mild to severe systemic disease. The most serious manifestations involve defects of the heart valves and aorta, which may lead to early death if not properly managed. The syndrome also may affect the lungs, eyes, dural sacs surrounding the spinal cord, the skeleton, and the hard palate. People with Marfan syndrome tend to be unusually tall, due to the disorder causing people with the condition to have long limbs and long, thin fingers and toes. The syndrome is caused by the misfolding of fibrillin 1, a glycoprotein which forms elastic fibers in connective tissue and contributes to cell signaling activity by binding to and sequestering transforming growth factor beta, TGF. The mutated fibrillin binds poorly to TGF, which results in an accumulation of excess TGF in the lungs, heart valves, and aorta. This in turn causes abnormal structure and function of vascular smooth muscle and reduced integrity of the extracellular matrix, which weaken the tissues and cause the features of Marfan syndrome. Named after Antoine Marfan, the French pediatrician who first described the condition in 1896, the disease is an autosomal dominant disorder. Management often includes the use of angiotensin II receptor antagonists, ARBs, and beta blockers. Signs and symptoms: more than 30 different signs and symptoms are variably associated with Marfan syndrome. The most prominent of these affect the skeletal system and are found in numerous other diseases. See differential diagnosis, below. Therefore, distinguishing Marfan syndrome from other Marfanoid syndromes requires the assessment of non-skeletal clinical and laboratory findings, especially of the eyes, aorta, and heart. Complicating the physical assessment of such persons, considerable clinical variability occurs within families carrying an identical DNA variant. Skeletal system: most of the readily visible signs are associated with the skeletal system. Many individuals with Marfan syndrome grow to above average height. Some have disproportionately long, slender limbs with thin, weak wrists and long fingers and toes. Besides affecting height and limb proportions, people with Marfan syndrome may have abnormal curvature of the spine, abnormal indentation or protrusion of the sternum, abnormal joint flexibility, a high arched palate, malocclusions, flat feet, hammer toes, stooped shoulders, and unexplained stretch marks on the skin. It can also cause pain in the joints, bones and muscles. Some people with Marfan have speech disorders resulting from symptomatic high palates and small jaws. Early osteoarthritis may occur. Other signs include limited range of motion in the hips due to the femoral head protruding into abnormally deep hip sockets. Eyes: in Marfan syndrome, the health of the eye can be affected in many ways, but the principal change is partial lens dislocation. The lens is shifted out of its normal position. This occurs because of weakness in the ciliary zonules, the connective tissue strands which suspend the lens within the eye. The lens can be seen as a trampoline surface supported by the zonules as springs. Fibrillin 1, FBN1, is a component of the zonules, and mutations in FBN1 are found in most individuals diagnosed with Marfan syndrome. Those mutations weaken the zonules and cause them to stretch. The inferior zonules are most frequently stretched, resulting in the lens shifting upwards and outwards, but it can shift in other directions as well. Nearsightedness and blurred vision are common, but farsightedness can also result, particularly if the lens is highly subluxed. Subluxation, partial dislocation, of the lens can be detected clinically in 80% of patients by the use of a slit lamp biomicroscope. If the lens subluxation is subtle, then imaging with high-resolution ultrasound biomicroscopy might be used. Other problems are a greater risk of retinal detachment, an earlier onset of cataract formation, and a high risk of chronic open-angle glaucoma. Rarely, the lens can dislocate through the pupillary opening to precipitate an ocular emergency, pupillary block glaucoma. The latter is rare, but in the context of direct ocular trauma in a patient with Marfan syndrome it should be ruled out. Cardiovascular system. The most serious signs and symptoms associated with Marfan syndrome involve the cardiovascular system, undue fatigue, shortness of breath, heart palpitations, racing heartbeats, or chest pain radiating to the back, shoulder, or arm. Cold arms, hands and feet can also be linked to Marfan syndrome because of inadequate circulation. A heart murmur, abnormal reading on an ECG, or symptoms of angina can indicate further investigation. The signs of regurgitation from prolapse of the mitral or aortic valves, which control the flow of blood through the heart, result from cystic medial degeneration of the valves, which is commonly associated with Marfan syndrome. See mitral valve prolapse, aortic regurgitation. However, the major sign that would lead a doctor to consider an underlying condition is a dilated aorta or an aortic aneurysm. Sometimes, no heart problems are apparent until the weakening of the connective tissue, cystic medial degeneration, in the ascending aorta causes an aortic aneurysm or aortic dissection, a surgical emergency. An aortic dissection is most often fatal and presents with pain radiating down the back, giving a tearing sensation. Because underlying connective tissue abnormalities cause Marfan syndrome, there is an increased incidence of dehiscence of prosthetic mitral valve. Care should be taken to attempt repair of damaged heart valves rather than replacement. During pregnancy, even in the absence of preconception cardiovascular abnormality, women with Marfan syndrome are at significant risk of aortic dissection, which is often fatal even when rapidly treated. Women with Marfan syndrome, then, should receive a thorough assessment prior to conception, and echocardiography should be performed every 6 to 10 weeks during pregnancy, to assess the aortic root diameter. For most women, safe vaginal delivery is possible. Lungs, pulmonary symptoms are not a major feature of Marfan syndrome, but spontaneous pneumothorax is common. In spontaneous unilateral pneumothorax, air escapes from a lung and occupies the pleural space between the chest wall and a lung. The lung becomes partially compressed or collapsed. This can cause pain, shortness of breath, cyanosis, and, if not treated, it can cause death. Other possible pulmonary manifestations of Marfan syndrome include sleep apnea and idiopathic obstructive lung disease. Pathologic changes in the lungs have been described, such as cystic changes, emphysema, pneumonia, bronchiectasis, bullae, apical fibrosis, and congenital malformations such as middle lobe hypoplasia. Central nervous system, dural ectasia, the weakening of the connective tissue of the dural sac encasing the spinal cord, can result in a loss of quality of life. It can be present for a long time without producing any noticeable symptoms. Symptoms that can occur are lower back pain, leg pain, abdominal pain, other neurological symptoms in the lower extremities, or headaches, symptoms which usually diminish when lying flat. On X-ray, however, dural ectasia is not often visible in the early stages. A worsening of symptoms might warrant an MRI of the lower spine. Dural ectasia that has progressed to this stage would appear in an MRI as a dilated pouch wearing away at the lumbar vertebrae. Other spinal issues associated with Marfan syndrome include degenerative disc disease, spinal cysts, and dysfunction of the autonomic nervous system. Pathogenesis. Marfan syndrome is caused by mutations in the FBN1 gene on chromosome 15, which encodes fibrillin 1. a glycoprotein component of the extracellular matrix. Fibrillin 1 is essential for the proper formation of the extracellular matrix, including the biogenesis and maintenance of elastic fibers. The extracellular matrix is critical for both the structural integrity of connective tissue, but also serves as a reservoir for growth factors. Elastic fibers are found throughout the body, but are particularly abundant in the aorta, ligaments and the ciliary zonules of the eye. Consequently, these areas are among the worst affected. It can also be caused by a range of intravenous crystal treatments in those susceptible to the disorder. A transgenic mouse has been created carrying a single copy of a mutant fibrillin 1, a mutation similar to that found in the human gene known to cause Marfan syndrome. This mouse strain recapitulates many of the features of the human disease and promises to provide insights into the pathogenesis of the disease. Reducing the level of normal fibrillin 1 causes a Marfan-related disease in mice. Transforming growth factor beta, TGF, plays an important role in Marfan syndrome. Fibrillin 1 directly binds a latent form of TGF, keeping it sequestered and unable to exert its biological activity. The simplest model of Marfan syndrome suggests reduced levels of fibrillin 1 allow TGF levels to rise due to inadequate sequestration. Although it is not proven how elevated TGF levels are responsible for the specific pathology seen with the disease, an inflammatory reaction releasing proteases that slowly degrade the elastic fibers and other components of the extracellular matrix is known to occur. The importance of the Tgf pathway was confirmed with the discovery of the similar Loeys-Dietz syndrome involving the TGFR2 gene on chromosome 3, a receptor protein of TGF. Marfan syndrome has often been confused with Loeys-Dietz syndrome, because of the considerable clinical overlap between the two pathologies. Management: there is no cure for Marfan syndrome, but life expectancy has increased significantly over the last few decades and is now similar to that of the average person. Clinical trials are also underway for promising new treatments. At present, 2013, the syndrome is treated by simply addressing each issue as it arises and, in particular, preventative medication even for young children to slow progression of aortic dilation if such exists. Since angiotensin II receptor antagonists, ARBs, also reduce TGF, these drugs have been tested in a small sample of young, severely affected people with Marfan syndrome. In some, the growth of the aorta was reduced. However, a recent study published in NEJM demonstrated similar cardiac outcomes between the ARB, losartan, and the more established beta blocker therapy, atenolol. Marfan syndrome is expressed dominantly. This means a child with one parent a bearer of the gene has a 50% probability of getting the syndrome. However, as the gene causing Marfan syndrome is known, arduous genetic techniques are able to circumvent this. In 1996, the first pre-implantation genetic testing therapy for Marfan was conducted. In essence, BGT means conducting a genetic testing on early-stage IVF embryo cells and discarding those embryos affected by the Marfan mutation. Regular checkups by a cardiologist are needed to monitor the health of the heart valves and the aorta. The goal of treatment is to slow the progression of aortic dilation and damage to heart valves by eliminating arrhythmias, minimizing the heart rate, and minimizing blood pressure. Beta blockers have been used to control arrhythmias and slow the heart rate. Other medications might be needed to further minimize blood pressure without slowing the heart rate, such as ACE inhibitors and ARBs. If the dilation of the aorta progresses to a significant diameter aneurysm, causes a dissection or rupture, or leads to failure of the aortic or other valve, then surgery, Possibly a composite aortic valve graft or valve-sparing aortic root replacement becomes necessary. Although aortic graft surgery, or any vascular surgery, is a serious undertaking, it is generally successful if undertaken on an elective basis. Surgery in the setting of acute aortic dissection or rupture is considerably more problematic. Elective aortic valve graft surgery is usually considered when aortic root diameter reaches 50 mm, 2.0 inches, but each case needs to be specifically evaluated by a qualified cardiologist. New valve-sparing surgical techniques are becoming more common. As Marfan patients live longer, other vascular repairs are becoming more common, for example, repairs of descending thoracic aortic aneurysms and aneurysms of vessels other than the aorta. The skeletal and ocular manifestations of Marfan syndrome can also be serious, although not life-threatening. These symptoms are usually treated in the typical manner for the appropriate condition, such as with various kinds of pain medication or muscle relaxants. It is also common for patients to receive treatment from a physiotherapist, using TENS therapy, ultrasound and skeletal adjustment. Citation needed. This could also affect height, arm length, and lifespan. A physiotherapist could also help improve function and prevent injuries in individuals with Marfan syndrome. The NUS procedure is now being offered to people with Marfan syndrome to correct sunken chest or pectus excavatum. Because Marfan syndrome may cause asymptomatic spinal abnormalities, any spinal surgery contemplated on a Marfan patient should only follow detailed imaging and careful surgical planning, regardless of the indication for surgery. Treatment of a spontaneous pneumothorax is dependent on the volume of air in the pleural space and the natural progression of the individual's condition. A small pneumothorax might resolve without active treatment in 1 to 2 weeks. Recurrent pneumothoraces might require chest surgery. Moderately sized pneumothoraces might need chest drain management for several days in a hospital. Large pneumothoraces are likely to be medical emergencies requiring emergency decompression. Research in laboratory mice has suggested the losartan, an ARB which appears to block TGF-β activity, can slow or halt the formation of aortic aneurysms in Marfan syndrome. Physical activity. The American Heart Association made the following recommendations for Marfan's patients with no or mild aortic dilation: probably permissible activities, bowling, golf, skating, but not ice hockey, snorkeling, brisk walking, treadmill, stationary biking, modest hiking, and doubles tennis. Intermediate risk: basketball, both full and half court, racquetball, squash, running, sprinting and jogging, skiing, downhill and cross country, soccer, singles tennis, touch, flag, football, baseball, softball, biking, lap swimming, motorcycling, and horseback riding. High risk: bodybuilding, weightlifting, non-free and free weights, ice hockey, rock climbing, windsurfing, surfing, and scuba diving.